Hi everybody, this is the talk on patterns in shoulder MRI. At the outset, I just want to let you know that it is good if you have a basic understanding of shoulder anatomy before you do this talk, but even if you don't, it'll be pretty helpful to you. Okay. So we're going to talk about 5 major diseases in the shoulder: the rotator cuff, anterior instability, posterior instability, adhesive capsulitis, and acromioclavicular disease. So the first thing we want to remember about MRI that's very helpful in all aspects of musculoskeletal imaging is that MRI signal depends upon the hydrogen proton from water to create a signal. The mobility of this hydrogen proton is directly proportional to the signal on proton density and T2 weighted images. In other words, if a hydrogen proton is not able to move much, you won't generate much signal when you apply T2 or PD sequences to it. Whereas if it is slightly mobile, then you will start to get some signal. So in a sense, more mobile water means more signal. So to simplify life, I say So to simplify life, I use in my imaging high resolution proton density images in all 3 planes to identify anatomy and confirm pathology. And I normally do one plane of T2 or PD fat suppressed images to look for edema. Now this is specific for internal derangements and should not be confused for tumor imaging or infection. So let's just try and understand tendinopathy, right? If we think about tendinopathy, what we really want to know about this is that we can see that this is the normal tendon. It's got collagen fibers that run very parallel to each other. And these are very well bound to each other. So invariably, you get no signal from this when you apply T2 or proton density signal. And this is sort of what it looks like, a nice dark tendon. If you look at ultrasound, you get a nice homogeneous parallel oriented appearance on ultrasound. When we think about tendinosis, it is basically some disruption of this architecture. The fibers become wavy, a little bit degenerated, and then on MRI you start to see some increased signal intensity. And on ultrasound, what you start to see is more heterogeneous signal within the tendon, not that normal linear architecture. And finally, when you have a tear, you have complete disruption of the collagen. So you get bright T2 signal where there's a tear. And obviously, when ultrasound, you see a discrete defect in the tendon. So it's easy for you to now understand how it is difficult at times when you have advanced tendinosis and a tear to differentiate between the two. And at that point, we start to look at the morphology of the tendon. We start to see continuity and other things. And clinically, what we would often call an interstitial tear or bad tendinosis, a clinician may call it a full thickness tear because there's a loss of function. On the other hand, that same person, if they have a bad looking tendon like this, but they have normal function, then they'll just say it's tendinosis. Okay. So here's an example of mild supraspinatus tendinosis. You can see a little bit of linear signal hyperintensity within the tendon itself and minimal subacromial bursal fluid. Here's somebody with moderate tendinosis. You can see more significant signal hyperintensity within the tendon, and you can imagine that that collagen is more degenerated or abnormal. And finally, here so there's some other things that you can determine when you see tendinosis in different locations. So for example, in this, you have tendinosis that's along the posterior supra and anterior infraspinatus, which is a common area to see tendinopathy in somebody with posterior impingement. In some situations, you can see tendinosis, that intersubstantial degeneration of the tendon, instead of just staying in the tendon, may track into the bone. Remember, the tendon and the bone don't sort of stick on each other with Fevicol. They interdigitate with each other. So that tendinosis, that degenerative change within the tendon can dissect into bone and form a cyst. And that cyst that forms can be clear. And sometimes that cyst, if it forms relatively quickly, will produce bone marrow edema around it. And if it forms slowly, may produce no bone marrow edema around it. So that's normal to see. And we commonly see this in the shoulder in association with the posterior supra and anterior infraspinatus, or the infraspinatus and subscapularis junction, or sometimes in the upper subscapularis attachment. Sometimes these cysts can track into the tendon and produce intratendinous ganglia, as you can see in this case here and here. In some situations, what one can see is we see a lot of edema around the tendon, and the tendon looks relatively normal. In these situations, one must look very carefully because one can see that these patients could be associated with calcific tendinosis. So calcific tendinosis is a condition where you get calcium hydroxyapatite deposition that happens within or adjacent to the tendon. And when this calcium liquefies, it produces intense inflammation around it, producing a lot of adjacent bursal fluid and edema. So when you see bursal fluid and edema and you start to see the tendon looking normal, remember to look very carefully for calcific tendinosis, and also look at the x-rays because they're a good place to make that diagnosis. Now, if we think about tears, we talk about tears in a couple of different ways. We talk about it from the thickness perspective of whether it is undersurface or bursal sided. And then if it is involving partial or 50% thickness or full thickness. Okay, so this is about how thick or what is the thickness of the tendon that's involved. We also have the width of the tendon that is involved. So in other words, this anterior portion here is going to be the supraspinatus, this posterior portion is going to be the infraspinatus, and the question is then whether we have a full thickness or partial thickness, full width or partial width supra and infraspinatus tear. So you understand the width is going to be more important on the sagittal images, the thickness is going to be more important on these coronal images. So here, for example, you have an articular sided, maybe it's 50 to 75% thickness, right? Because it is that thickness of the tendon that is involved. So 50 to 75% thickness tear of the anterior supraspinatus. So now whether we decide this is the full thickness of the supraspinatus or it's a little bit less than that, that's going to be a little subjective. But otherwise, I would say there's a 50% thickness under surface, partial thickness, near complete width supraspinatus tear. Okay, so are you guys understanding? Thickness is the actual thickness of the tendon, whereas the width is whether it is involving supraspinatus alone or supraspinatus plus infraspinatus. Okay. Now this is an example of a bursal sided tear. Now these are very easy to miss. So you can see these small little slender footprint tears, they're called, almost at the attachment. These are very easy to miss. They can be quite painful. When they are bursal sided, they can be very difficult to pick up when you do an intra-articular arthroscopy. And when you do then sometimes you have to do a subacromial bursal arthroscopy to be able to see these tears. So this is a bursal sided footprint tear. Again, it is near full thickness, and then the width will be based on the sagittal images, whether it's involving supra, infra, or just the anterior supra. Most often these tend to be anterior supraspinatus tears. Here's a full thickness supraspinatus tear. You can see the tendon is retracted to the level of the glenohumeral joint, and you can see there's a lot of subacromial synovitis and bursal fluid. This is a patient who had rheumatoid arthritis. So when you think about these tendons, you think about trying to determine whether it's tendinosis or tears. Remember what I told you about MRI and collagen appearance and the changing signal with that. Remember we talked about interstitial tear versus bad tendinosis. We talked about when we see unexplained edema or fluid, we start thinking about looking for calcific tendinosis. And when we're describing tears, we're going to describe them based on their craniocaudal thickness as full thickness or partial thickness. We're going to say whether it is more on the articular side or bursal side. We're going to indicate what percentage of the tendon thickness was involved. And then when we say it's the width, we're going to say whether it's the full width of the supraspinatus, partial width of the supraspinatus, or full width of the supra and infraspinatus. Okay. Now, when it comes to the subscapularis, we have a slight difference in the way of looking at it. The fibers run slightly obliquely. Our MRI images are straight axial. So occasionally you have some volume averaging. And in those cases, you will tend to overcall subscapularis tendinosis and tears. I find the sagittal images are a great place to look at the subscapularis. So that's what I tend to use to trace the subscapularis best. One of the things besides normal subscapularis tears, with the subscapular tears and comes down here and you can see subluxation of the biceps, is you can see that there's continuity of the subscapularis fibers, but the patient may have lost function. Okay, and this is just stripping of the fibers along the length of the subscapularis that occasionally happens. So when you read these scans, you'll say that the subscapularis looks continuous, but the surgeon will say there's no subscapularis function. Now here's a deep fiber tear of the subscapularis, and you know this has happened because the biceps has subluxed medially. Once you see biceps subluxation medially, you think that the deep fibers of the subscapularis are torn, because that ligament that you were taught about always, the bicipital ligament that holds the biceps tendon into the groove, is actually just a condensation of the deep fibers of the subscapularis. Here's a small focal superior subscapularis tear. So this is a tiny little tear in the superior subscapularis. Now, once you've looked at the tears and identified them, the next thing you want to know is what is the status of the muscle. And this is particularly important because it helps the surgeon to decide whether function will return or not. And here we have to remember two things. One is the muscle mass. So you can see in this case, this muscle is sort of normal. In this case, you can see the muscle mass has reduced quite a bit. So this is what we would typically call volume loss. Okay. On the other hand, this is the supraspinatus. On the other hand, if you look at the teres minor here, the muscle mass is pretty good, but you can see that there's fatty infiltration or this marbled appearance inside this teres minor. So that is called fatty infiltration. And it's important to differentiate volume loss and fatty infiltration because volume loss can come back. If a muscle becomes atrophic, you bring it back, you have somebody exercise, the muscle volume loss will return. But if you have somebody who's got fatty infiltration of the muscle, that fatty muscle to convert to normal muscle is very difficult. So I always say whether there is muscle volume loss and fatty infiltration as two separate entities. Now, here you can see a patient who's got teres minor fatty infiltration, and this is a fairly common thing. We see teres minor fatty infiltration all the time, and this is often related to it can be related to a ganglion cyst in the quadrilateral space which impinges upon the axillary nerve. But oftentimes we have sort of some occult axillary nerve injury which leads to denervation of this muscle. It usually does not result in any alteration of function. Now, one of the things to remember also over here is if we think about the nerve supply to the shoulder, there is a suprascapular nerve. This nerve runs across the suprascapular notch and then down the the spinoglenoid notch here posteriorly. So it can be impinged upon by paralabral cysts typically. And when paralabral cysts impinge upon this nerve, they can produce other denervation effects or muscle edema. So for example, in this case, you can see this is a spinoglenoid notch cyst. And in this spinoglenoid notch cyst, what happens is that the cyst is in the spinoglenoid notch where the nerve to the infraspinatus is, and that results in denervation edema of the infraspinatus. The nerve to the supraspinatus has already taken off in the suprascapular notch, and therefore the supraspinatus is not affected. If the cyst is in the suprascapular notch, occasionally you may see denervation of both these muscles. Okay? But sometimes, even in the suprascapular notch, the nerve to the supraspinatus may be spared and you'll just see infraspinatus atrophy and edema. The last thing that we're going to look at in the rotator cuff is in terms of, is going to be the migration of the humeral head. So when you see superior migration of the humeral head, it's an indicator to you of chronicity and from the surgeon of saying that this patient may have a guarded prognosis if we go back and fix the rotator cuff. So always look for humeral migration. So when we're thinking about the rotator cuff, we're going to think about a few different things. First of all, tendinosis versus tears. Secondly, the unexplained edema. And you're going to think of calcific. The third thing is tears, whether they are full thickness or partial thickness, articular-sided or bursal-sided. The extent of involvement, whether it's partial supraspinatus, entire supraspinatus, supra and infraspinatus or subscapularis. We talked about the subscapularis and how that's a bit different tendon because you can sort of mistake tendinosis and tears. Whenever you're done describing the muscle, the tendon, start thinking about the muscle, whether there is muscle volume loss and fatty infiltration. And when you have volume loss and fatty infiltration, try and think of whether it's come because of a tear or there's a secondary denervation effect. If you have tears, look at humeral head migration because that can be an indicator that somebody may not respond well to surgery. And finally, if you have cartilage loss, obviously that's an important thing to mention because it means what are you trying to protect and what do you have to do next, and maybe that person needs a shoulder replacement. So we've talked about the rotator cuff tears, describing them, muscle volume loss, the important pertinent positives and negatives when we start thinking about that. Now the next thing I'll move to is anterior instability. So this is the next most common reason why you get scans. Anterior instability is a situation where there is anterior dislocation of the humeral head. When this happens, there are typically three structures affected: the anterior inferior glenoid and its labrum, the posterior superior humeral head, and the capsule. So at the anterior inferior glenoid, you get a labral tear of a variety of different types with associated bony lesions. Posterior superior humeral head, you get impaction, which is called a Hill-Sachs lesion. And then finally, you have some disruption and stripping of the capsule itself. So if we think about a labral tear, it's like kicking a door open. Okay, in this situation, if you were to get angry and you kicked the door open, depending on where you kicked the door, how hard you kicked the door, how weak the door was, you'll have different things that will happen. Either the hinge will break, the door will break, the hinge will come off the door jamb, or the door jamb itself will break. And what you see on imaging is basically a variation of these appearances. So for example, here is if you kick the door hard, you will break the door, the hinge, and that hinge will come off the door completely. And this is your classic Bankart lesion. In a Perthes lesion, what happens is the hinge comes off, but it's just hanging by a single screw. So you have stripping of the periosteum and the labrum over here. In a Glad lesion, what happens? You kick the door and a bit of the door jamb also comes off. So you have a cartilage lesion along with the labral tear. In an Alpsa lesion, you kick the door open, but then the hinge also comes off and it flips inside. So now it becomes very hard to fix the door again. So this is sort of an Alpsa lesion, or what is called an anterior labral periosteal sleeve avulsion. So the labrum comes off, the periosteum strips off, and the labrum buckles inside. So this can't heal back normally. And finally, sometimes you kick the door and it's locked on the opposite side. So you break it at the handle side. And then this is what you would get is called a haggle, or a humeral avulsion of the glenohumeral ligament. Now, whenever we see labral tears, typically they are fixed by something called arthroscopy, where they put sutures in and they can fix that labral tear. Okay. But sometimes when you have recurrent dislocations, there's more than a labral tear and the bone has also thinned out and come off. When that happens, we call it glenoid bone loss. Okay. And when we have glenoid bone loss, we're interested in knowing how much glenoid bone loss there is, because that helps to determine whether this patient will benefit from conservative arthroscopic surgery or may need a bony surgery. So when we're looking at calculating glenoid bone loss, you want to get a good sagittal image of the entire glenoid, where it looks like, some people used to say pear, Donald Resnick calls it an avocado, but depending on what your experience with vegetables is, it looks basically like this. And what you want to do is you want to estimate what the normal diameter of this glenoid is. Then what we'll do is we'll draw the normal diameter of the glenoid. And when we have a patient who's got anterior instability, we draw that best fit circle so that it matches the posterior inferior quadrant around here of this glenoid. And then we look at the area of bone that's lost and we measure the distance of bone loss. And basically the percentage bone loss is the bone loss divided by the estimated diameter as a percentage. And if you have bone loss that is greater than 20 to 25%, then those are patients who will typically not benefit from just arthroscopic surgery and may need also to get a bony reconstructive surgery. Okay. So what is the bony reconstruction surgery? Most of the time what they do is they take a piece of the undersurface of the coracoid and they stick it back here with 2 screws. And that is something called a Latarjet surgery. And that's how they reinforce the anterior inferior glenoid. Sometimes you can have dislocations, and as I mentioned to you, you can have Hill-Sachs lesions. So Hill-Sachs lesions can come in a variety of different flavors. They can be big flat lesions like this. They can be small depressed lesions like this. And one has to be careful about not misinterpreting intraosseous cystic change from rotator cuff tendinopathy for a Hill-Sachs lesion. Okay. If there is a large Hill-Sachs lesion, then what they can do is they can basically go and take a pass of the infraspinatus, fill it in that gap, and then that will prevent the patient from redislocating. So that is called a remplissage surgery. So you have 2 ways in which you help with instability. One is on the humeral side and 2 is from the glenoid side. Another concept that you need to be aware of is an engaging or a non-engaging Hill-Sachs lesion. An engaging Hill-Sachs lesion is where during routine acts of movement, the humeral head slips out. Whereas a non-engaging lesion is one that requires a certain amount of force to come out. For an engaging lesion, people are more likely to do something more than just arthroscopic repair, and they would want to go and do some bony reconstructive surgery or at least work on the Hill-Sachs lesion. So if we want to understand pre-operatively whether somebody is going to be an engaging or non-engaging Hill-Sachs lesion or anterior instability patient who will require a bigger surgery than just an arthroscopic surgery, then we have to do some estimations and measurements and understand something called the on and off track phenomenon. In order to do this, we have to first understand something called the glenoid track, which is essentially the amount of glenoid that is available for articulation. Okay. In a normal person, 83% of the glenoid is available for articulation. In a patient who's got bone loss, it is 83% of the normal glenoid minus whatever bone loss is available that is available for articulation. Similarly, on the humeral side, the entire spherical humeral head is available for articulation in a normal person. But when somebody has a Hill-Sachs lesion, that portion of the humeral head that is flattened is not available for articulation. And that transverse portion in the axial plane is called the humeral track, or the distance of the humerus that's not available. Now, if the humeral track exceeds the glenoid track, then that person has a higher likelihood of going into engagement. So let's look at this example. We have a patient here. This is a normal glenoid. You can see the normal diameter. This is a patient, and 83% of that diameter is available for articulation. This is the patient with glenoid bone loss. You can see that that's the normal diameter that's available. And basically that small d is the amount of bone loss. And 83% of the total diameter minus this small d is going to be the residual track that is available for articulation. The Hill-Sachs lesion is going to be this transverse measurement here. So you can see this is the Hill-Sachs lesion. Sometimes the Hill-Sachs lesion could be more medial, in which ways we take the transverse measurement of the Hill-Sachs lesion and also the distance of the Hill-Sachs lesion to the infraspinatus. Okay, and that gives you the humeral track. Okay. If you have a patient who has a humeral track that is longer than the glenoid track, then that patient is going to be something called an engaging Hill-Sachs lesion, or engaging or off-track morphology, which requires surgical intervention. So take, for example, this case. You have a humeral track, which is the width of this Hill-Sachs lesion to the cuff footprint tear. That is this width. We don't care about craniocaudal. We don't care about depth. We just want to know this width. And then we have somebody here where we have the glenoid track, which is the normal glenoid diameter, 83% of it, minus the bone loss, which gives you the total amount of the residual glenoid track. And again, if the humeral head or the Hill-Sachs or the humeral track exceeds the glenoid track, then that means you have an engaging morphology. So what are some variations you can get with instability? You can have a soft tissue Bankart lesion, which will typically go to arthroscopic repair. You can have a big Hill-Sachs lesion and a small Bankart lesion, which will go to a remplissage because you just want to put infraspinatus and pack up that infraspinatus. You can have a small Hill-Sachs lesion and a large Bankart lesion, so bony loss in the range of 20 to 25%, in which case you would do a Latarjet procedure, which is bringing the coracoid process down. And finally, if you have both that are very large, then you can do both the Latarjet and the glenoid reconstruction, but it's very, very rare to do both procedures together. So in summary, I've tried to explain to you that anterior instability is the interplay between the glenoid, the humeral head, and the capsule. Soft tissue glenoid lesions, that means your simple Bankart lesions, ALPSA, Perthes, GLAD lesions, these can undergo arthroscopic management. The moment there's bony involvement and there's bone loss, then you have to reinforce the bone and you do something called a Latarjet procedure. Anytime there's dislocation, you develop a Hill-Sachs lesion. If that Hill-Sachs lesion is very big, then you do a remplissage lesion. And today, the concept of anterior instability revolves around understanding whether something is engaging or non-engaging, with non-engaging lesions getting arthroscopic reconstructions and engaging lesions requiring larger surgeries like remplissage or Latarjet procedures. Okay. So hopefully we've understood something about anterior instability. Now, posterior instability. Posterior instability and multidirectional instability can happen for a couple of reasons. One is you can have acute posterior instability, which is a posterior dislocation event. Here you'll have a reverse Hill-Sachs and a posterior labral tear. And you have chronic injuries, which is because of capsular overload. And we'll explain both ways. So here, for example, this is a standard patient with posterior dislocation. The humeral head dislocates posteriorly. You get a posterior labral tear and you get an impaction injury at the anterior aspect of the humeral head. So this is called a reverse Hill-Sachs lesion. And here you have a posterior labral tear. And obviously the injury is along the anterior capsule in this case. So here's a typical MR example of that. You can see in this video, there's posterior humeral head bone marrow edema. Anterior humeral head bone marrow edema. And you can see this big posterior labral tear at here, which is related to the posterior dislocation event. The other concept that we need to understand is posterior instability. Now, this typically happens in throwers. So in our practice, we don't see that many. It doesn't seem to happen so much in our cricketers and our fast bowlers, but it happens much more in our gym-going population. So people who go and do bench pressing, sometimes even our overhead athletes, so badminton players, these are the people who tend to get this. It was traditionally described in baseball pitchers. And what happens in this condition is because you pull back your shoulder and you try to push forward, every time you do that, you create micro injury to the inferior capsule. So you get repeated inferior capsular stretch, right? Um, when you throw, and what that leads to is inferior capsular injury. Okay, now once you get the inferior capsular injury and stretch, so you can see that injury down here, right? You can have anterior and posterior and usually inferior capsular injury. That leads to inferior capsular scarring. So once you have scarring, you have constrained inferior mobility. So normally when you would move your shoulder into an abducted position, your humeral head tends to descend, but because that capsule is very thick, the humeral head does not come down, and therefore the humeral head moves up. Now, when it moves up, it increases the loading on the posterior superior labrum. That results in posterior superior labral tears, and it also results in some impingement upon the posterior superior cuff, so the posterior supraspinatus and the anterior infraspinatus, right? So therefore, all these conditions, posterior instability, internal impingement, posterior inferior rotational, internal rotation deficit, these are all within a spectrum of similar conditions. Now what happens is, as you keep loading that posterior compartment starts to get angry and pushes the humeral head forwards. Now, as it's pushing the humeral head forwards, the biceps in the front gets angry. So you get bicep strain and instability. As you get loading on the biceps flattens. It becomes like a little knife edge because it's flattened, and it starts to cut into the superior subscapularis and the anterior supraspinatus, producing tears there. So we'll see how this looks. So how does this happen? You have somebody who's doing bench presses. So they have a loaded anterior capsular stretch. You get anterior capsular micro tears. You get restricted anterior humeral head mobility. You get posterior impingement. And then this, again, the posterior thing pushes anteriorly and the whole process continues. So here, for example, you can see somebody who's got inferior capsule is normal here. You can see the posterior inferior thick capsule in this patient. Now you can see this in adhesive capsulitis also, but usually these patients will not produce with that adhesive capsulitis picture clinically. The second thing that you can see is, you can see there's a lot of thickening of the posterior capsule. Sometimes you can even see bony remodeling along the posterior inferior capsule, which is called a Bennett lesion. So then as you sort of keep doing this, there's a peel back lesion that happens on the biceps labral junction because of the increased external rotation. So what happens is, you can see this in a normal thrower, you can see the biceps will restrict anteriorly and the capsule restricts this person. But now gradually, as the head moves posterior superiorly, the head will start to impinge upon the posterior superior capsule and biceps labral junction, and you start to get biceps labral tears over here. So on MRI, what will you see? You can see biceps labral junction tears, like you can see here. So this is a humeral head, the glenoid, and you can see the labral tear here. You can see small superior labral tears, like you can see here. You can see posterior superior tears, so extension into the posterior superior labrum, and then sometimes you can see paralabral cysts forming in association with those posterior labral tears. As I talked about earlier when we were talking about the cuff, because these patients get posterior superior loading, they start to develop tendinopathy that involves their posterior supra and anterior intraspinatus, and sometimes they can also develop articular-sided tears. So this would be a typical patient who's got posterior superior, who's got like a GERD-like situation, a chronic thrower. You'll see that there's posterior supra and anterior infraspinatus tendinopathy. You'll see there's inferior capsular thickening, and you can see that bone remodeling along the posterior glenoid, which is that Bennett lesion. And along with that, you can see this labral tear over here. So now once your posterior structures have started to protest, there's an increased load on the anterior structure, which is the biceps. This leads to flattening of the biceps, micro instability, and then as it becomes micro instability, it becomes like a little saw that moves back and forth and starts to cut up the anterior supra and superior subscapularis. So here you can see a normal patient. You can see the biceps having this nice ovoid appearance. This is the supraspinatus. This is the superior glenohumeral ligament. This is the coracohumeral ligament and the subscapularis. This is a patient who has biceps tendinosis, and this is a patient who has a biceps tendon tear. Okay, so that's how you can identify biceps tendinopathy. Now, in our patients with instability, what you can see is this is the normal biceps tendon. You can see somebody who's got instability. You can see the biceps is more flattened, almost having a knife-like appearance. Here you can see it's subluxed inferiorly because it's cutting into the subscapularis, and here it's sort of dislocated completely into the subscapularis here. Okay, so this is good ways for you to see and identify abnormalities with the biceps at this rotator interval area. Now, as this biceps rubs across that area, it produces bone marrow edema in the humeral head at its point of transection, and that we get something called a chondral print, or this bone marrow edema in that region. So posterior instability, just to summarize, is a situation where we get repeated inferior capsular stretches. The repeated inferior capsular stretches lead to inferior capsular scarring. The inferior capsular scarring leads to constrained inferior mobility, which means the humeral head starts to move superiorly and posteriorly especially. This starts to load on the posterior superior labrum and the posterior rotator cuff, so the posterior supra and anterior infraspinatus. This leads to increased loading. As they push forward, they will load on the biceps and lead to biceps instability, and that biceps will then lead to cutting changes on the anterior supra and the anterior supra and superior subscapularis. Okay, so we've talked about posterior instability in the acute and the chronic phases. Now moving on to adhesive capsulitis. Adhesive capsulitis is a frozen shoulder. It's a painful shoulder on account of capsular inflammation. It's usually without cause, seen more common in diabetics, post-traumatic or calcific patients. And we also see it quite a bit in the COVID era because of maybe vaccine related changes. So whenever we see this clinically, these can present as small rotator cuff tears, calcific tendinosis, especially in the acute or chronic stages, greater tuberosity fractures, distal clavicular stress reactions, and infection or inflammation. So in this, typically it goes to a 2 to 4 month duration of 3 phases: freezing, where there's just capsular inflammation; frozen, where there's capsular inflammation along with capsular tightening. So it's a painful movement, but not much movement either. So painful with restricted movement. And finally, a thawing phase, where the capsular inflammation goes away and you have restricted motion with reduced pain. So what happens in this? In the freezing patient, what you'll have is you'll see this rotator interval scarring and edema up here. You can see this inferior capsule, mild thickening and edema. Right? In the frozen phase, you can see the capsule is much thicker. There is capsular edema. And then in thawing phase, what you'll see is there's thick capsule, but there's no edema associated with the capsule. Okay, so that's sort of the 3 phases that you'll see with adhesive capsulitis. So adhesive capsulitis is an important thing to remember, but also to remember that capsular edema is something that you can see with other conditions also. So every time you see capsular edema, don't go down the path of calling adhesive capsulitis. Look at the picture as a whole. So if you have calcific tendinosis, you can have edema because the calcification is near the capsule. If you have greater tuberosity fracture in trauma, you can have capsular injury, so you'll have capsular edema. So that's not frozen shoulder, right? So these are some things that you should remember. Okay, finally moving to the acromioclavicular joint. The acromioclavicular joint has got a superior and inferior capsule, a meniscus homologue that runs within it, and it's got cartilage. It's got ligaments that hold it together. So you have the acromioclavicular ligaments and you have the coracoclavicular ligaments. And here you have 2 ligaments: the conoid one, which is more medial, and the trapezoid one, which is more lateral. And then you have something called an os acromiale, which is basically the format in which the acromial apophyses fuse. So here is an example of the coracoacromial ligaments, your conoid and trapezoid portions that you can see here. Here are your superior and inferior acromioclavicular ligaments. This is the os acromiale. The os acromiale has got 3 parts. It's got the preacromion, the mesoacromion, the metaacromion. And normally the os acromiale happens at the junction of the meso and the metaacromion over here. The main things to remember with this is it can have edema. So the first thing you remember is you can see this very commonly at least until the age of 21. So when somebody is below the age of 21, don't call an osochromia and just say it's an unfused apophysis. Right? It may or may not have bone marrow edema associated with it, and it may or may not have symptoms associated with it. Okay? These can lead to instability, so the bone can become unstable and cause pain. Sometimes that bone becomes unstable and can cause impingement as well. Another thing that people talk about commonly is looking at extrinsic impingement upon the shoulder by abnormal positions of the acromion, so abnormal acromial tilt. I'm not a big believer in this. Sometimes I see large hooks, but oftentimes you see people with hooks and all sorts of other things that don't actually have any impingement. So the clinical correlation between the presence or absence of a hook and the presence or absence of impingement is very poor. So I don't normally go into this type 1, type 2, type 3 descriptions or go into these things. Now, when you have chronic acromioclavicular joint loading, you can have micro instability, which leads to capsular thickening and edema and early osteoarthritis. When you have overload, you can have also, especially in weightlifters, you can have, these guys who go to the gym and all that stuff, you can have distal clavicular stress fractures. And once you have distal clavicular stress fractures, you can develop osteolysis. So they get a little bit of subcondylar cystic change, and then it seems like the clavicle is getting resolved. So chronic AC strain, you can see a little bit of capsular edema here, capsular strain, then micro instability resulting in degenerative bone marrow edema. Then you can see a little bit of the bone remodeling happening along the inferior aspect here with subchondral cystic change. Then you can see here that there's a patient who's been a regular workout guy who's got distal clavicular bone marrow edema and a subtle stress fracture over here. Here you can see somebody who's got chronic changes, there's that cystic change, and because of which there's a little distal clavicular osteolysis, or there's just overload related widening of the acromioclavicular joint. And finally, here you can see distal clavicular resorption with a small little piece of leftover bone over there. So this is just a spectrum of changes that you can see with the AC joint. Now, when you see distal clavicular osteolysis or bone loss, you should think about a few other things. Rheumatoid arthritis, you can have AC joint inflammatory synovitis. You can have infections. You can have hyperparathyroidism that can be an issue with these patients who have distal clavicular osteolysis, tumoral calcinosis, and certain tumors, obviously, of the distal clavicle. So this is early ACOA. This is sort of mild with a little bit of fluid and edema, and this is more moderate to severe AC joint osteoarthritis. Okay, so it's just showing you a progression from mild to moderate and advanced. So here is a grade 1 injury. You can see a little bit of capsular edema and disruption. Here again, you can see that. Here's sort of a grade 2 injury where you can see there's widening of the acromioclavicular joint. And then here's a grade 3 injury where you can see there's disruption of the coracoclavicular ligaments that run between the acromion and the coracoid. So coracoacromial ligaments. So this is disruption of the coracoclavicular ligaments, which is seen in a grade 3 injury. Okay. Now, in some patients, when you have widening of this, you can have subacromial bursal fluid, and this subacromial bursal fluid will break out through this AC joint and come into the subcutaneous tissues, and that's something that it will produce called a geyser sign. So a geyser is basically a hot water spring that comes out from the ground, and so somebody who saw this felt that this underground water was coming through the AC joint and coming out as a geyser, and so they called it the geyser sign. It's not to be mistaken for the geyser that is in your bathroom. So whenever you see AC joint injuries, always look carefully. Sometimes you can see, so whenever you see edema anywhere, and this case is a good example for that, especially in the shoulder, one is immediately inclined to think that a particular structure is damaged. But if we look at this case very carefully, we see that there's edema along the coracoacromial ligaments. And we were very quick to think that maybe this is an injury to this coracoacromial ligament. But when we talked to the patient, there was not much injury and the AC joint looked relatively good. When we look on the non-FATSAT images, we can see very nice coracoacromial ligaments, right? And so this patient, we looked at very closely, this was actually a hypointense focus here, and this was calcific periarthritis that was sitting next to the coracoacromial ligament or along the anterior aspect of the coracoid process. So what we've talked about with the acromioclavicular joint, we talked about the developmental issue. So the os acromiale, don't call it below the age of 21, and whether it can produce potential impingement or micro instability related pain. We've talked about chronic AC joint loading resulting in instability, stress fractures, osteolysis, osteoarthritis, and then we've talked about some other causes of osteolysis. We talked about trauma affecting the acromioclavicular joint capsule and the coracoacromial ligaments. And finally, we talked about across the entire shoulder. If we see edema that's unexplained, remember to look very, very carefully for calcific periarthritis. So that goes through our entire list of rotator cuff instability, posterior instability, adhesive capsulitis, and acromioclavicular disease. So basically, the major disease patterns in the shoulder, one is in the rotator cuff. We talked about tendinosis, tears, the importance of talking about muscle volume loss versus muscle atrophy or fatty infiltration, migration of the humeral head, and the status of the cartilage. In anterior instability, we discussed the Bankart lesion, the Hill-Sachs lesion, bone loss, and the concept of engagement and non-engaging Hill-Sachs lesions and in anterior instability. In posterior instability, we talked about acute posterior instability with the reverse Hill-Sachs and the posterior labral tear. And then we also talked about the concept of capsule-related or chronic overload-related capsular injury resulting in posterior impingement, which could be the same compendium of things, which is posterior impingement, posterior internal rotation deficit, multidirectional instability, among a few other things. We talked about adhesive capsulitis and how it is important that just because we see capsular edema, it doesn't mean it's adhesive capsulitis. And we talked about the acromioclavicular joint in acute situation with acute trauma and on a more chronic loading